take the opportunity to introduce our next speaker, who's Andrew Bowker. Andrew is probably well known to most people here already. He's a very experienced surgeon working from Auckland. He's basically led the way with laparoscopic preperitoneal hernia repair, and I'm looking forward to your talk very much, Andrew. Welcome.
Right, we'll try again. I work full-time as a private surgeon in Auckland, Aotearoa, New Zealand. Just briefly, my pedigree and justification for giving this talk in TEP. I've done over 9,000 laparoscopic hernia repairs. The vast majority of these have been using the TEP technique. I first got into laparoscopic surgery when I was working in Australia. So my next slide's not coming up. Here we go. When I was working in Australia, so I've borrowed this advertisement from a New Zealand condom manufacturing company to cover this time. TEP, more challenging to learn than TAP, but does avoid any intra-abdominal adhesions that may be present, and of course cuts out the movements of opening and closing peritoneum. It's my preference. First tip is to audit your practice. At present, our colleagues in Australia are setting up a hernia registry, which will be a fantastic thing to have. But currently, this is the situation with most surgeons. In public, they operate, they just discharge their patients to their general practitioner, and that's the end of it. So effectively, they're operating in a void. In private practice, it's a little better. The patient is at least seen in their early post-operative period, but then discharged, they may come back if they've got problems, or they may go and see another surgeon. Ideally, you should be doing some sort of audit. 3-month review is a minimum, and if you're keen, you can do more extended reviews. I've done both of these things through various times of my practice, and this informs me about what I do and gives me justification for what I do. So what do I do? My technique is essentially the same for all different hernias. Primary, recurrent, bilateral, reducible, massive, and post-radical prostatectomy. If there's a recurrence following a previous laparoscopic repair, I switch back to using a TAPP approach. Ports all in the midline, the 10mm port within the umbilicus. I bias the scar to the side of the repair. This is because, in my experience, the most common cause for a patient having a recurrence is thinking they have a recurrence, when in actual fact, it was the contralateral side that I repaired. This at least gives them some indication as what's been done before. The most caudal port is 3 finger breadths above the symphysis pubis. This gives room for the mesh to be folded up on this anterior edge. The third port goes midway between the two. You'll notice I use a purse string suture in the anterior rectus sheath. This creates a very effective seal to stop gas escaping, and there's no bulk to it. This is actually an old picture. We still use non-disposable instruments though, so I use ceramic 5mm ports for my operating ports. All ports are in the midline. I avoid trauma to muscle. And just while I'm on this, a midline scar can be a deterrent for people looking at laparoscopic hernia repair. But with this approach, you can slide off to the side. If you've got a bilateral hernia, instead of trying to cross the midline laparoscopically, it's best to do the two sides as separate repairs simultaneously at the same time, of course. I no longer use a balloon to dissect. My initial dissection is done at the end of my 10mm scope. This gives me enough space to introduce my operating ports. I do those by supporting the abdominal wall with the 10mm port, so that the introduced 5mm port does not inadvertently damage deeper structures. I've always favoured a 0 degrees laparoscope, easier orientation, but you can still get very easily disorientated if your camera holder rotates their wrist. So if things are looking a little strange inside, check what their wrist is, what that camera is doing. Even a few degrees of rotation can be quite disorientating in this this landscape, which is rather devoid of anatomical cues. This is blunt dissection, TEP. I very rarely use sharp dissection. Keep the instrument tips close together for greater control. It also guides your camera operator. I start laterally and develop my operating space before being distracted by the hernia. If there's any common thread to people struggling with this operation, it's failure to develop an adequate extraperitoneal plane before tackling the hernia. You're going to have to do it anyway to fit the mesh, so do it at the beginning. Also, if you've made a decent sized space, if you inadvertently make a hole in the peritoneum, which I frequently do, the space will not collapse upon you. Indirect hernias, I favour getting the sac out completely, even very large sacs. The trick to this is to get around the sac early during the mobilisation, clearing the cord structures off the posterior edge. Having done that, you can then be much more aggressive with your reduction of the sac out of the inguinal canal. Direct hernias, I always invaginate the attenuated transversalis fascia and pin it to the superior pubic ramus. An alternative is to use an endoloop, but it's not as effective in obliterating the dead space. I use a pretty basic sort of mesh, flat, wide pore, mid-weight. I find lightweight meshes too floppy. They don't sit well when you let the gas out. 15 by 10 is the standard size here in New Zealand. I know the Australians use have a tendency to use larger mesh, but I gather quite often it's trimmed down.
And we are presenting today an interesting.
Someone's coming in over my talk. Yeah. Routine titanium tack fixation is my preference, but I only fix medially. I'll talk about this a bit more laterally, and I won't show the video in the interest of time. I'll post it on our WhatsApp sometime after this conference. Another tip, patients should be able to do whatever they like immediately after this operation. Almost all surgeons who I have feedback from still advise their patients to avoid any heavy lifting for 4 weeks or 6 weeks after this operation. They're not really thinking about what's been achieved with a laparoscopic repair. That mesh, once it's positioned correctly, is not going to go anywhere. There's very little movement within the pelvic frame, which is where the mesh is. Right from the start of doing this operation, I've encouraged people to get stuck in. I've told them they can do whatever they'd like. They can go and bench press that afternoon. I don't care. They can even go pole dancing. And this is a fellow day one after his operation, which I did recently. Recurrence. We as surgeons tend to be somewhat optimistic about our recurrence rates. This is what I estimate my recurrence rate to be to the best of my abilities. I did look at this at one stage back in the early 2000s, attempted to contact 1,000 consecutive hernia repair patients, managed to get hold of 700, and nothing was uncovered during this audit that we did not already know about. So I think my figures are reasonably accurate. More importantly, pain following hernia surgery. This here looks at restrictions using medium weight mesh, routine titanium tack fixation, medially only. And you'll see no one has any restriction to speak of. And this is total lack of restriction at 12-month follow-up. Looking at pain or awareness, even at 3 months, all people are experiencing is occasional twinge. That's the mild pain. There are 4 patients there who had moderate, described as moderate pain. No one was severe. As hoped, at 12 months, this graph moved to the left, and you're just left with just over 6% of people who have some awareness of the operation, some reminders, but they're generally not troubled. So, fixation. People who fix with penetrative fixation tend to do this. They fix medially. They tend to be a little bit anxious about fixing to the periosteum of the superior pubic ramus, so they have a tendency to slide alongside it, and they fix laterally. So what happens with mesh is that it contracts, and this applies to all meshes. Heavyweight mesh a lot. Lightweight meshes that tend to be used now, not so much, but they still contract. And what happens is these points of fixation drag through the muscle as the mesh contracts. And using an absorbable tack does not prevent this from happening. Most of this retraction happens in the first 3 months or so, is my understanding. So I think that is the commonest cause for chronic pain in laparoscopic hernia repair where fixation is used. The alternative is to use no fixation at all. There's a risk of that mesh contracting and exposing the posterior wall of the inguinal canal. An answer is to position your mesh across the midline, but then you reduce the cover of the deep ring by shifting the mesh across. And Most recurrences that I've had to deal with, be it my own or other surgeons, the recurrence has been under that posterior lateral border of the mesh, and it's an indirect recurrence. What do? I anchor that mesh heavily to the superior pubic ramus, plus or minus to the linea alba, again, between muscles, and have no fixation laterally, so that when the mesh contracts, it slides across the muscle and does not impact on the muscle and does not cause pain. And fixing to the superior pubic ramus does not cause pain either. I do this very firmly, and when I invaginate the transversatus fascia of a direct defect, I anchor that to the superior pubic ramus also. You might also notice that I've actually trimmed the mesh along the line of the superior pubic ramus. This is a modification that I introduced to my practice over 20 years ago out of concern for my urological colleagues who complain about this operation, making it difficult for them to do radical prostatectomies. I've had feedback from surgeons in Auckland, urologists in Auckland, saying that this simple maneuver of reducing the amount of mesh down in that retro pubic space makes their life a lot easier. And one of them in particular will allow that to influence whether he offers a patient surgery or not. So other situations, cord lipoma, easily overlooked. What I do before I go into do a hernia repair is have a look at my clinical notes and see what sort of size I thought that hernia was. If the sac that I find laparoscopically does not correspond to that size, then there will be a lipoma of the cord. It's good practice to actually routinely apply some traction on the spermatic cord at the level of the deep ring and draw it gently inwards, whereupon a cord lipoma pops into view. If you don't do that, you will miss it. They're easy to mobilize off the cord structures and get on the backside of the mesh. Irreducible hernias. Ramesh Panjami, can you turn off, please?
Yeah, so as you rightly mentioned, Rahul, pre-optimization.
Irreducible hernias. Large irreducible hernias, I do a combination of an open and laparoscopic approach. These big irreducible hernias have already disrupted the external ring. If you make a skin crease incision, you come down straight onto the sac, open the sac, mobilize the adhesions, reduce the contents, and while I'm there, I'll mobilize the sac itself up to its neck and transect it, tie it off, and then do a TEP repair. You do not increase morbidity because no muscles are being cut. Patient's recovery is just as if they'd had a standard TEP repair. Femoral hernias, the hook diathermy, as we saw in the previous talk, is the ideal instrument to diathermy, to divide the lacunar ligament medially to allow reduction of the femoral hernia. Spigelian hernias, TEP is a great way to approach these. You do the same initial dissection as for an inguinal repair, swing it more cephalad, and you can access that Spigelian hernia well. Lumbar hernias, getting off topic a little, but a fun operation to do should you be lucky enough to be referred one of these. TEP is a very valid way of doing it. You have to think about where you're going to put your ports, but it's a nice operation to do. And post-radical prostatectomy, I do all these using TEP. I now have a series of over 170. I avoid a balloon dissection definitely in these cases because otherwise the peritoneum may tear against the scarring. Very important to start your dissection laterally and swing it medially. All scarring is in the posterior wall of the inguinal canal. Most of these hernias are indirect, so the sac by definition is free. You dissect this back, then the key is to clear enough of the posterior wall of the inguinal canal so that adequate cover of mesh circumferentially can be achieved. And generally I can expose the full extent down to the pubic ramus. So that brings me to the end of the talk. What I've covered is covered in much more detail on a handout I give to people on my hernia courses. If you're interested, feel free to contact me directly on my email or I guess through the WhatsApp, and I'm happy to send one of these things through to you. And as I said before, I'll pop that video on some stage. Thank you very much.